Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today, I'll be discussing anemia, the classification based on MCV and reticulocyte. This part of CVME syllabus 8 sum. So, let us think what is anemia. Anemia is defined as a decrease in the circulating red cell mass, and this can be manifested as reduced hemoglobin, hematocrit, or RBC count, and leading on to various symptoms. So, anemia by definition is decrease in the RBC mass, and this can manifest as decrease in the hematocrit or hemoglobin, or decrease in the RBC count. And usually by WHO definition, the hemoglobin less than 13 grams in adult male and 12 grams in adult female and 11 grams in children and in pregnant women is considered as anemia. Hope the definition of anemia is clear. Hemoglobin less than 13 grams in adult males and 12 grams in females can be considered as anemia. Morphologically, depending upon the MCV, you divide the anemia into microcytic, macrocytic, and normocytic. So the normal MCV is 80 to 100. So that is the normal. So basically the classification is as microcytic anemia, macrocytic anemia, and normocytic anemia. So let us look into what are the causes for each one. The microcytic anemia, where the low MCV, the common conditions are iron deficiency, thalassemia, lead poisoning, and anemia or chronic infection sometimes. Normocytic normochromic anemia typically seen in or classically seen in anemia of chronic disease like rheumatoid arthritis, tuberculosis, and most important, chronic kidney disease. It can occur in acute bleeding. Suppose there is hemorrhage RBC, there will be anemia, but the MC will be normal. In hemolysis, sometimes you can get. So then comes the high MCV, that is classically seen in disorders of DNA synthesis. Typically, this is occurring in B12 and folate deficiency. This can occur due to drugs like acetylthymidine, methotrexate also. So now we go into little more into the macrocytic anemia, the causes of macrocytic anemia. One is reticulocytosis. Reticulocytes are young RBCs and they are larger, and any disease of the impairment of DNA, that is synthesis, like folic acid, B12 deficiency, drug effect already mentioned. Liver disease is another thing that you should keep in mind. Hypothyroidism, myelodysplastic syndromes. Any hemolysis, there will be, as mentioned, reticulocytosis leads on to large cells. So this is the morphological classification. Now depending upon the Barrow function, how will you assess the Barrow function? It is by looking at the amount of reticulocytes. Reticulocytes are young cells. When the number is increased, that means increased production. If the number is less, there is a decreased production. So this is the development of RBC from the proerythroblast going to the reticulocyte and then becomes the mature erythrocytes. By reticulocyte percentage, we mean the percentage of young cells or reticulocytes. But the problem is the reticulocyte count can be misleading, especially when the number of RBCs are less in patients with anemia. So we go for corrected reticulocyte count. So how will you do the corrected reticulocyte count? Think that a patient has got a reticulocyte percentage is 2%. The reticulocyte is 2%. We will do a correction for the anemia, that is a hemoglobin or hematocrit. So this will be multiplied by the patient's hemoglobin. Take it as 7.5 and the normal hemoglobin. Instead of hemoglobin, you can use the hematocrit also. So here it will be 2 by 2 is equal to 1%. So the corrected reticulocyte count is always lesser than the reticulocyte percentage. We go for one more correction for the maturation time. So that is the next correction, and by that you get what is called a reticulocyte production index. You can simply think that the hematocrit is between 15 to 25. The correction is around 2. Is a time taken for the reticulocyte to become mature. So here if it is the hematocrit is 7.5 means the hematocrit will be less than 25. So multiply by the 3 is the hematocrit. So it will be less than 25. So the correction will be 2. So this 1 should be divided by 2 and the corrected reticulocyte or the reticulocyte production index is now 0.5. Whenever the reticulocyte production index is less than 2, we say that the patient has got a decreased marrow or is a hypoproliferative anemia. So depending upon the reticulocyte production index, we divide the marrow into hypoproliferative and hyperproliferative. Whenever there is a nutrition deficiency like iron deficiency, B12 deficiency, folic acid deficiency, etc., or marrow suppression in aplastic anemia, the reticulocyte production index will be less than 2%. Whenever there is hemolysis, or when there is hemolysis, usually you get a increased reticulocyte production index. Hope this point is clear to you. So this is the, I will repeat once more. Reticulocyte percentage is corrected by for the hematocrit or hemoglobin. Patient's hematocrit or hemoglobin divided by the normal hematocrit or hemoglobin. That is, then you go for the reticulocyte production index. That is correct reticulocyte count divided by maturation index. Between 15 to 25, it is easy to remember, it is 2 divided by 2. So always reticulocyte production index is lesser than that of the reticulocyte count or reticulocyte percentage. So let us take a case where the patient has got a hemoglobin is 9, hematocrit is 9 into 3, that is 27, MCV is 70, and reticulocyte percentage is 1. So what type of anemia is this? So this is undoubtedly the hemoglobin is 9, so it is less than 13 in an adult male. So the patient has got anemia. What type of anemia? This anemia is, the volume is 70, so it is a microcytic anemia. And the reticulocyte is 1%, so you can say it is a hypoproliferative anemia. So anemia by itself is not a diagnosis, it is a beginning of investigations. So the most common cause of microcytic hypochromic anemia is, for a hyperproliferative anemia, is iron deficiency. So we'll check do the iron study. The one is ferritin. Ferritin normally is 15 to 200. Less than 15, you can definitely say that the patient has got a storage iron is less. But again, remember the ferritin is a acute phase reactant. So this can be elevated in chronic inflammation. Then you check the serum iron. Serum iron is normally 50 to 170 micrograms. And then you go for the total iron binding capacity. Normal 250 to 400 micrograms. Then the transferrin saturation. In iron deficiency, the saturation will be less than 15%. The transferrin saturation and iron binding capacity will be increased because less amount of iron is attached to transferrin. So we have discussed the pathologically you divide into hyperproliferative and hyperproliferative anemia. So when the reticulocyte production index is less than 2%, it is hyperproliferative. More than 2%, it is hyperproliferative. Now you summarize or the classification of anemia based on reticulocyte count. Reticulocyte index less than 2.5 or less than 2, take it as 2, it is hyperproliferative. More than 2.5, it is hyperproliferative. Hyperproliferative occurs in hemolysis, various causes of hemolysis. And the hyperproliferative nutritional anemias you can get, and various types depending upon the MCV you divide into. Less than 80, it is microcytic, 80 to 100 normocytic, and more than 100 macrocytic. Macrocytic already you have mentioned the various causes. Most important, this folate deficiency and B12 deficiency, alcoholic liver disease, hypothyroidism, myelodysplasia. Normocytic, the anemia of chronic inflammation, renal failure, marrow failure. Microcytic, iron deficiency, thalassemia, anemia of inflammation, sideroblastic anemia, and lead poisoning. These are the things you should remember. So, today we have discussed about the classification of anemia based on MCV and based on the reticulocyte. And we have divided the various types of anemias morphologically, pathologically, and depending upon the volume. Hope this was useful to you. Stay tuned. Thank you.